Welcome back to the deep dive. If you're tuning in, you're probably looking for some solid, quick insights into something that affects millions, migraine. And we know this isn't just your garden variety headache. It's a serious neurological condition, really debilitating for a lot of people, can knock you out for days, right? Stuck in a dark room. So our mission today is pretty clear. We want to cut through the noise, give you a proper, structured look at what the research told us. Causes, the different phases, triggers, and importantly, the modern ways to actually manage it. We're aiming to get right to the heart of it. So maybe let's start right there at the chemical level. What's actually happening in the brain to kick off this whole process?
Okay. Yeah, what's really interesting is that a migraine is, at its core, a neurological thing. It gets triggered by these temporary sort of abnormal swings in brain chemical levels. And these changing levels, they overstimulate the brainstem. That
Hmm.
stimulation then causes the blood vessels in the meninges, those are the protective layers around your brain, to first squeeze tight, constrict, and then open up, dilate way more than usual. And it's that big dilation, that excessive opening, that creates the really intense pounding pain people describe.
Gotcha. So it starts with a chemical hiccup, leading to this painful reaction in the blood vessels. And if we're talking chemicals, the sources point to one major player, CGRP.
Exactly. CGRP, calcitonin gene-related peptide. That's the molecule you really need to remember here. It's key because it does two main things. It directly causes that blood vessel dilation we just talked about, and it also transmits pain signals. And the research shows that people with migraines often will release too much of this stuff. It basically throws the switch for the headache to start and keep going. This peptide, CGRP, is why some of the newer treatments are so targeted.
Right, that makes immediate sense why those new drugs work the way they do. Okay, so for someone listening, maybe wondering, is this me? Cora, what are the key symptoms? What makes it a migraine and not just a really bad headache?
Yeah, the symptoms definitely go beyond just how much it hurts. Usually it's a throbbing kind of pain, often felt in one spot, maybe the temple, behind the eye, back of the head. But the real telltale signs, the things that scream migraine, are the other sensitivities that come with it. Things like feeling sick, nausea, sometimes vomiting. And then there's this intense sensitivity to light. We call that photophobia and sound, phonophobia.
Photophobia and phonophobia. Wow, so those sensitivities can be extreme then, like normal light or sound becomes painful.
Exactly. For some people, even just normal conversation or the lights in a room or the hum from a fridge can feel unbearable.
And it's not just like, boom, headache. You mentioned it's a process with phases. Understanding that seems really important for managing it. Can you walk us through those four phases?
Right. It's definitely more of an event, often unfolding over several days, not just the headache part. First up is the prodrome. This can happen a day or two before the actual headache hits. Think of it as your body's early warning system. You might feel neck stiffness, maybe unusual fatigue, sudden food cravings, or even shifts in your mood, like irritability or feeling low.
Okay, subtle warnings. Then what?
Then comes the aura. Now, not everyone gets this, maybe only about 25–30% of people. But if you do, it's a very distinct neurological sign. It often involves vision changes. People might see shimmering lights, maybe zigzag lines, sometimes described as white lights with jagged edges, or they could just have blurred vision. It usually lasts less than an hour and happens right before the headache.
So the aura is like a direct heads up the pain is coming. And then phase 3 is the main event.
Phase 3 is the headache itself. This is the period of severe, often disabling pain, along with those classic symptoms, the nausea, the extreme sensitivity to light and sound. This can last anywhere from 4 hours to, unfortunately, up to 3 days.
3 days.
Yeah.
Wow. And it's not over even when the pain stops.
No, that leads to phase 4, the postdrome. People often call this the migraine hangover. The worst pain might be gone, but you're often left feeling completely drained, maybe confused, dizzy, and still quite sensitive to things for another day or so, like your brain is slowly recovering.
That sounds exhausting. Less like a headache, more like your whole system just went through the ringer. Okay, that phase structure is really helpful, but let's tackle a big myth, the idea that a migraine has to be on only one side of the head.
Ah, yes. That's a really common misconception, but it's definitely not true. While it often is unilateral, meaning on one side, the sources are very clear. Migraines can absolutely be bilateral, affecting both sides of the head, or sometimes the pain might even switch sides during the same attack. So if you have that severe throbbing pain plus nausea, but it's on both sides, don't dismiss it as not a migraine just because of the location. The type of pain and those accompanying symptoms are much more important clues.
That's a really crucial clarification. Okay, so if someone's listening and thinking, yeah, this sounds like me, what are the more formal ways doctors diagnose this? And is there like a quick check people can do themselves?
For a formal diagnosis, doctors often use criteria from the International Headache Society, the IHS. It's quite specific. You generally need a history of at least 5 attacks that fit the pattern. Each attack needs to last between 4 hours and 3 days. And then, the pain needs to have at least 2 of these 4 features. Is it one-sided? Is it throbbing? Is it moderate to severe? And does it get worse with or make you avoid normal activity?
Okay, 2 out of 4 of those pain types.
Right. And plus, during the headache, you also need to have at least one of the following.
Yeah.
Either nausea, maybe vomiting, or both photophobia, light sensitivity, and phonophobia, sound sensitivity.
Wow, 5 attacks lasting up to 3 days each. That takes serious tracking. It really underlines how significant this is. Is there a simpler way for someone to get an initial idea?
Yes, thankfully. There's a well-validated screening tool called the ID Migraine Self-Check. It's pretty reliable for a first pass. It just asks 3 simple questions. During your headaches in the last 3 months, have you felt nauseated or sick to your stomach? Second, has light bothered you more than usual? And third, has the headache limited your ability to work, study, or do what you needed to do for at least 1 day?
Okay, nausea, light sensitivity, and did it stop you in your tracks for a day? What's the threshold?
If you answer yes to 2 out of those 3 questions, there's a very high probability, the studies show around 84% sensitivity, 76% specificity that you're experiencing migraines. It's a great starting point before talking to a doctor.
That's super useful, something people can use right away. Okay, let's switch gears to managing this because, understanding what sets it off the trigger seems like half the battle. If you can avoid the trigger, maybe you avoid the attack. Let's break down the trigger categories our sources mention, starting with behavior. That feels very relevant today.
Yeah, the behavioral triggers are often things we potentially have some control over. A big one mentioned is office syndrome. That neck and shoulder stiffness you get from hunching over a computer or staring down at your phone for hours.
Oh yeah, definitely feel that sometimes.
That muscle tension can absolutely be a trigger for some people. Then you have the more well-known ones. Stress, not getting enough sleep, or just general sleep disruption. Sometimes just improving posture or sorting out a better sleep routine can make a real difference.
Makes sense. What about things we can't really control, like the environment?
Right. Environmental triggers. These can be things like bright or flickering lights, think sunlight flashing through trees when you're driving, or maybe fluorescent lights in an office. Weather changes are another big one for some people. The sources mention things like really hot, humid weather, or that change in pressure just before it rains. Those can be potent triggers.
Okay, now for the tricky one, food factors. Everyone seems to look for that magic food trigger or cure. What does the evidence actually point to as potential culprits?
Well, the list that comes up consistently includes things like aged cheese, alcohol, pretty much any kind, MSG, monosodium glutamate, artificial sweeteners, and foods with nitrates like hot dogs, sausages, ham. Caffeine is also on the list, but it's a bit tricky. If you drink a lot of coffee or caffeinated drinks regularly, suddenly stopping can actually cause a withdrawal headache that feels like a migraine. So for caffeine, it might be about managing intake, maybe reducing it gradually rather than cutting it out completely.
That's a good nuance, but we really need to emphasize something here, right? The sources say only about 20% of people can reliably link their migraines to specific foods.
Exactly. That's a crucial point. Only 1 in 5 patients. It means for the vast majority, like 80% of people, the trigger is probably something else. Behavioral, environmental, stress, sleep, hormones. It's important not to go crazy eliminating foods unnecessarily if they aren't actually your trigger.
Good reminder. And speaking of hormones, that's the last big category, especially for women.
Yes, hormonal factors are significant. Migraines have a strong link to rapid drops in estrogen levels. This is why they often happen right around the menstrual period, maybe the day before it starts, or in the first few days. It also explains why some women experience them frequently after giving birth, when estrogen levels fall sharply.
And the sources also caution about certain medications, like birth control.
Correct. Birth control pills or any medication containing estrogen can potentially influence migraine patterns because they affect hormone levels. It's definitely something women with migraines should discuss with their doctor, how their hormonal medication might be interacting with their headaches.
All right, so we understand the condition, the phases, potential triggers. Let's talk about the actual management plan. Before even thinking about pills, what are the top 3 behavioral things people should focus on?
Okay, 3 key behaviors. First, and maybe most obviously, diligently avoid your known triggers. Once you've identified them, whether it's lack of sleep, certain lights, Stress. Actively try to manage or avoid them. Seems simple, but it's foundational. Second, exercise regularly. Things like brisk walking, cycling, swimming, moderate aerobic exercise helps regulate brain chemicals and releases endorphins, which can naturally help suppress migraines.
But there's a warning there too, right? Don't overdo it.
Yes, absolutely. For some individuals, very intense, strenuous exercise can actually be a trigger. So the emphasis is on regular, moderate activity, not pushing yourself to the absolute limit if that seems to cause problems.
Okay, avoid triggers. Moderate exercise. What's the third one? It's about when you feel an attack coming on.
Exactly. The third crucial behavior is rest immediately. As soon as you recognize those early warning signs, the prodrome symptoms, or the very beginning of the headache, stop what you're doing if possible. Find a dark, cool, quiet room and just rest for 10 or 20 minutes. That immediate sensory withdrawal can sometimes stop the migraine from fully developing or at least lessen its severity.
Makes sense. Damage control right at the start. Okay, now let's get into acute treatment, the medication you take when the migraine actually hits. It seems like there's a step-by-step approach.
Yes, it's usually staged based on severity. For milder attacks where you're pretty sure it's a migraine but it's not overwhelming yet, the first recommendation is often paracetamol, which is acetaminophen. It can be effective if taken early.
Okay, start simple. What if it's more severe?
For more severe pain, the next step up is usually the NSAID class, non-steroidal anti-inflammatory drugs. Think naproxen or ibuprofen. They work well for many people, but, and this is important, they really should be taken with food or right after eating to protect your stomach. And here's a really critical warning from the sources. You have to be very careful with how often you use NSAIDs for headaches. The recommendation is strict. No more than 4 to 10 tablets per month. Overuse can lead to serious issues like liver or kidney problems and even rebound headaches.
Wow, only 4 to 10 doses a month maximum. That really hammers home why just relying on popping pills isn't sustainable and why prevention is so key. Okay, what's the next level up? The really migraine-specific drugs.
The triptans. Exactly. Triptans like electriptan or sumatriptan are a class of drugs designed specifically for migraines. They work differently from general painkillers. They target serotonin receptors in the brain. This action helps to constrict those overdilated blood vessels in the meninges, getting them back towards their normal size, and it also helps block pain pathways. It can be very effective, often working within an hour or two.
Highly effective. But you mentioned serious warnings earlier. Can you stress those again? Who absolutely should not take triptans?
Yes, this is incredibly important. Because triptans work by constricting blood vessels, they are strictly contraindicated, meaning absolutely should not be used by people who have a history of coronary heart disease, like angina or heart attack. Also, anyone with cerebrovascular disease, like a history of stroke or TIA, mini-stroke, or peripheral vascular disease, which affects blood flow in the limbs, using triptans in these conditions could be dangerous.
Okay, so major cardiovascular restrictions. Any other usage limits?
Yes, similar to NSAIDs, there are limits on frequency. You shouldn't take more than 10 doses of triptans in a single month. And doses of the same or different triptans need to be spaced out, usually at least 12 hours apart, depending on the specific drug. Always follow the specific instructions.
Okay, the fact that even the most effective acute meds have such strict limits really pushes us towards preventative strategies, doesn't it? If you're hitting those 10-dose limits month after month, prevention seems like the only way forward. When do doctors typically start talking about prevention?
That's exactly the point. Preventative medication is generally considered when migraines are frequent and settle. The usual threshold is experiencing 4 or more migraine days per month. Or it's considered if the attacks you do have are particularly severe or long-lasting, even if less frequent. Also, if you can't take or don't respond well to the acute medications, maybe due to side effects, those cardiovascular contraindications we discussed, or even pregnancy, then prevention becomes the main strategy.
And the goal is pretty compelling, right? Reduce how often they happen.
Yes, the aim is to significantly cut down the frequency, severity, and duration of attacks. The sources suggest that using preventative medication consistently for about 6 to 12 months can potentially reduce migraine frequency by up to 50% for many people.
Okay, that's a huge potential improvement in quality of life. Now, looking at the types of preventative meds, it's interesting we see drugs originally used for other things, like depression or seizures. Why do those work for migraines? Seems unrelated at first glance.
That's a great question, and it confuses a lot of people. The short answer is that migraines involve more than just blood vessels. There's an element of brain nerve cells being overly excitable or unstable. And it turns out that the mechanisms these other drugs use to stabilize nerve activity, for say seizures or mood, also help calm down the processes that trigger migraines.
Ah, okay. It's about calming down the underlying electrical instability in the brain. Makes sense. So what are the main types of oral preventative meds doctors might use?
Right. In the oral category, there are a few main classes. First, certain tricyclic antidepressants, like amitriptyline. Even in low doses, they can help stabilize brain chemicals involved in pain and mood. They're often a good first choice, especially if someone also has trouble sleeping or experiences tension headaches or that office syndrome neck pain, as they can help with those too. Second, some anticonvulsants or anti-seizure medications like topiramate. These work by basically dampening down that nerve cell hyperexcitability. Topiramate in particular has shown good results for reducing menstrual migraines maybe by around 33%. But like all meds, it can have side effects, commonly things like drowsiness or maybe some tingling or numbness, especially when starting.
Okay, antidepressants, anticonvulsants. What else?
Third, certain beta blockers, like propranolol. These were originally developed for high blood pressure, but they also seem to affect blood vessel tone and nerve signaling in ways that help prevent migraines. They might be around 25% effective for migraine prevention, so they're a particularly good option if a patient happens to also have high blood pressure that needs managing.
Fascinating how these different classes work through overlapping pathways. All right, finally, let's talk about the newer options, the cutting edge, which seems to blow us back full circle to CGRP, but this time with injections.
Exactly. While nerve blocks, like the occipital nerve block, injecting anesthetic near nerves at the back of the head, have been used for chronic migraine for a while with some success and few side effects, the really big development is the anti-CGRP medications. These are a newer class of drugs, biologics known by brand names like Aimovig, Ajovy, and Emgality. They are specifically designed to target CGRP itself, or its receptor. Remember how we said CGRP causes vessel dilation and pain signals? These drugs block that action.
And they seem quite effective compared to the older oral options.
Yes, the data is promising. They are typically self-injected, maybe once a month or sometimes quarterly, depending on the drug. Studies show they can reduce migraine frequency significantly, again, often by 50% or more for many patients. A big advantage is that they tend to have fewer widespread systemic side effects compared to the older daily oral medications because they're so targeted. The main downside noted in the sources is that they're currently quite a bit more expensive than the older generic options.
This has been incredibly thorough, really taking us from the basic chemical trigger right through to these advanced treatment strategies. Let's try and wrap this up. What's the single most important takeaway message you want our listeners to leave with today?
I think the core message is this. While migraines, thankfully, don't usually cause permanent brain damage, they absolutely wreck your quality of life. Understanding your own pattern, the phases, the triggers, is power. Prevention is so much better than constantly chasing the pain with acute meds, especially given the limits on those meds. So work with your doctor, get a proper diagnosis, understand your treatment options, and never try to manage these powerful medications on your own. Use the knowledge about triggers and phases to adjust your lifestyle proactively.
That's excellent advice. Knowledge is power. Know your enemy, right? Okay, as we finish this deep dive, here's a final thought for you, the listener, to ponder this week. We heard that only about 20% of people can clearly point to food as their trigger, but almost everyone deals with modern life stress, maybe poor posture from screens, disrupted sleep. Given that strong link mentioned between physical tension, like neck stiffness or office syndrome, and headache onset, maybe think about this. What other overlooked behavioral factors, something beyond just the usual suspects of sleep and diet, could be playing a key role in your symptoms? Try a little holistic self-assessment this week. Thanks for joining us on the Deep Dive.